So, Prakash, thank you very much.
Thank you. It is a privilege, and I do hope filling John Dark's shoes is a tall order, but I'll try my best, and thank you very much for giving me the opportunity to discuss. I won't go too much, but it's just quite important always to refresh the specific shape and the dimensions that do change during the cycle. Mitral regurgitation is commonly observed in patients with heart failure. It is associated with poor prognosis. And we know that repair or replacement to restore competency is a well-established procedure when there are symptoms of heart failure. And primary disease is disease of the valve leaflets. But the question comes when it is functional or secondary, where the valve leaflets are not normal but do not fully coact because of the dilatation or the restricted leaflet motion, secondary to enlarging size or sparsity. Obviously, this is commonly associated with low ejection fraction and heart failure symptoms of 3 or 4. Again, just to go through, progressive LV remodeling is characterized by progressive dilatation, which causes annular dilatation, papillary muscle displacement, chordal tethering, all of which contributes to development of mitral regurgitation, which may start off as very mild, but continues to keep on getting worse. Surgery in this situation is controversial only because the MR is a consequence and not really the cause of LV dysfunction, and prognosis therefore is more related to the underlying cardiomyopathic process. Also, it's a sort of cycle where you have functional MR, which leads to, as we went very eloquently in the first 2 talks, increase in the P load, the wall tension, and then it contributes to a worsening situation. So the presence of functional MR itself is an independent risk factor for poor outcome, both in non-ischemic and ischemic etiologies, and it's been many papers that have told us that. Dion even contributed further to say that uncorrected mild MR as well as moderate to severe with ischemic is associated with a reduced long-term survival. So far so good. What about the patients we can help? Is it safe to repair valves in heart failure patients? And the answer to this has to be an emphatic yes. There was a thought that all patients with ventricular dysfunction and MR would suffer if their valves were made competent, as they would lose their pop-off mechanism. But this has been disproved many years ago. Bowling did it extremely well more than 15 years ago, where he had a very, very acceptable operative mortality of 5% in more than 140 patients, which also showed that there was reverse remodeling as evidenced by a decreased left ventricular endoscopic diameter, improvement in ejection fraction, improvement in NYHA class, and the sphericity index. This was replicated again by B-Shape from the Cleveland Clinic, who again demonstrated a very low mortality in operating in these patients with severe LV dysfunction, and were also then able to demonstrate reverse ventricular remodeling. There have been many attempts to use various kinds of rings, and we are going to concentrate on the functional MR ischemic cardiomyopathy or the dilated cardiomyopathy, depending on what the pathology is being presented. So current evidence clearly indicates that the presence of functional MR identifies a high-risk group among patients with LV systolic dysfunction, and that increasing severity of MR adds to this risk. What is less clear is whether this functional MR is a marker of severity of LV dysfunction or its attendant volume low contributes to further progressive LV dysfunction, and thus should be a target for therapy. What does the Heart Failure Society of America guidelines state? This is a general guideline where they recommend that the decision to undertake surgical intervention should be in the light of functional status. Prognosis based on severity and comorbid conditions, something we are all very aware of in the current environment, and that it should be done in centers where there is demonstrable expertise, multidisciplinary surgical and medical team experience in the selection care, perioperative, as well as long-term management of these patients. When you look at the recommendation 10.3, mitral valve repair or replacement, isolated repair or replacement for severe MR, secondary to ventricular dilatation in the presence of severe, is not generally recommended. But the strength of the evidence is level C, and so that again puts us not very clear. Let's look at Michael Acker. I think you must have read, and he presented 5 years ago a very, very low mortality in patients who had the core cap. And this was a 5-year follow-up where they presented the 5-year safety and efficacy of mitral valve with and without the core cap in patients with dilated cardiomyopathy and YHA 2 to 4. So this was from the original Acorn trial, which had 300 patients, but 193 were involved in the mitral valve repair replacement stratum. 102 were randomized to mitral valve surgery alone, which was the control group, and 91 had, in addition, implantation of core cap. Just to refresh you, core cap is this elasticated sleeve that goes around the AV groove and protects further after surgery. So their previous reported 30-day mortality was only 1.6. At 5 years, the total mortality was 30% with an average of 6% per year. The effects of mitral valve surgery led to progressive decrease in LV and diastolic and end-systolic volumes, which were highly significant at all time points. At the end of 5 years, there was an average reduction in LV and diastolic volume of 75 mils, which is a 28% reduction from baseline. Over 5 years of follow-up, 29 of their patients had recurrent mitral and 5 underwent repeat mitral surgery. So the addition of core cap led to a greater decrease in left ventricular and diastolic volume, average difference of 16.5. That addition of a core cap has an additive effect to the mitral procedure. There's just a graph to highlight their very, very acceptable levels of mortality. So they concluded that the long-term improvement in LV structure and function provide evidence that mitral valve repair in combination with core cap in patients with severe LV dysfunction have been medically optimized is recommended. Now, we went a step further to try and see what we need to do in order to tackle patients who don't leave it too late. We saw just being spoken about. And if you see in the patients of group that we were interested in surgery in moderate MR undergoing CABG, it's class 2AC, which again leaves a little bit of room because it's just a consensus of opinion of experts, but no trial. MR occurs in up to half of the patients of varying degrees, mild, moderate to severe, clearly moderate and severe in a lesser percentage, but it is an independent predictor of mortality by multivariate analysis, and more than one person has confirmed that. And up to 12% had more than moderate or more MR, and again was a predictor of reduced survival. If you look at independent predictors of reduced survival after CABG, moderate MR again was an independent predictor. And another patient who were undergoing and found that increasing MR was again an independent risk factor for not only death, but also development of further heart failure. But the limitations of these existing studies were there were no prospective randomized controlled trial. Most of the studies are small, retrospective, observational. Late MR is either not reported or significant late recurrence of MR is reported. And important surgical principles to ensure successful and durable valves is not very clear at that time. Mihalovic from Cleveland did a very good job, but the problem was again there was a use of dominant partial flexible bands and only less than a quarter which had rigid complete ring. And although their results were better, they did not show such a significant improvement. There has been some controversy about the definition of MR, and we're trying to clarify it as compared to tricuspid. And also there has been controversy in cost effectiveness, and we've used to say that the earlier we target, the better it is. This was a randomized ischemic mitral evaluation trial which was presented at the AHA, and the results. subsequently fast-track publication into the circulation. We were very surprised that it went on to reach first in Editor's Pick as well as first in the AHA Journal's Pick. We had previously commented that functional MR occurs in up to 40% of patients following MI. It's a result of LV remodeling and dilatation. Mitral valve is tethered and pulled apart, usually mild or moderate, but once it crosses moderate, it increases the heart failure and death by up to 3 times. And of course, they have triple vessel disease and would benefit from CABG. But CABG alone results in persistent risk of heart failure. The effect of adding mitral valve to this group of moderate is uncertain. Observational studies do report a reduction, but no improvement in functional capacity. And these studies were all non-randomized and had significant recurrence rates, up to varies between 30 and 70% depending on where you look at literature. And we also felt that there was no standardization of the technique. Ours was a single-blinded, clearly surgeon had to do the procedure, so he could not be blinded. It was randomization on a 1-to-1 ratio in CABG only, as well as CABG plus mitral valve. But we were very keen to maintain complete rigid or semi-rigid IMR etiologics, sized by measurement of anterior leaflet, downsized by 2 if an alternative complete ring, or a standard downsized IMR etiologics. The aim was to get a coaptation of at least 8 millimeters and do not leave the OR with more than mild MR. So important principles: complete CABG, complete ring or semi-rigid, not flexible bands, undersized to achieve coaptation at 8, no more than trace MR. In the interest of time, I won't go through all the study, but the inclusion criteria was referred for elective, must have moderate, as defined by criteria, which is ERO more than 20, but up to 39, rigorous involvement between 30 and 59, fraction between 30 and 49, and vena contracta between 0.3 and 0.69. Our primary hypothesis, as you can understand in view of the last number, was adding annuloplasty with moderate MR improved functional capacity, and secondary was to improve LV reversing modeling and DNP levels. Primary endpoint at 1 year was again functional capacity assessment was blinded, and secondary was LV reverse remodeling, MR volume, and BNP. There was no doubt an increase in the bypass and cross-clamp time as expected, because it does increase. But the important thing was that 85% of the links were EMR, 15% were physio, and the mean size was 28. There was significant functional capacity improvement in patients who had undergone, in addition to mitral CABG, there was significant LV reverse remodeling, and there was, of course, reduction of mitral regurgitation as compared to patients who had CABG only. There was also improvement significant in patients in YHA class as compared to patients who underwent only CABG. We found improvement, not very strongly as compared to other parameters, but there was improvement at BNP at 1 year as well. At 1 year, there were still further improvements in NYHA class. The study was limited by the fact that when we had the first review, we had some, but the second, which was the interim results, we had to stop the study because there was clearly a significant benefit. As I explained, it is a single, not double-blinded trial. Endpoints were determined at 1 year, and we are following up further. And it is not designed nor powered to evaluate clinical events and survival. So our conclusions were, compared to CABG alone, the addition of mitral valve annuloplasty to CABG in patients with moderate functional MR improves functional capacity, improves LV reverse remodeling, clearly improves presence of mitral regurgitation, and there is improvement in BNP levels. Long-term clinical outcomes remain to be defined, and we follow up the patients and come back. Yes, CABG plus annuloplasty did require longer operation times, increased hospital intubation and hospital stay, but hopefully that will reflect in reduced re-hospital admissions, and concomitant CABG plus mitral valve annuloplasty should be considered in patients with moderate functional MR. Thank you very much.